Good morning and a very warm welcome to today's webinar. This is first of its series, which is being conducted before the first Symposium of SOGP. Grateful to all worthy speakers, our chairpersons for today's session, and our very own President SOGP, Madam Professor Razia Kurejo, and all members nationally and internationally who have joined us for this meeting. And the three speakers for today's session, I'm really very glad to welcome you all on today's webinar. May I now formally request Madam Razia Kurejo to give welcome remarks and start today's meeting.
Dear all SOGP members, all the viewers, and all the healthcare providers, and all the speakers. Just I want to tell you first thing, when I entered in this office, I heard sad news of Professor Nadeem Shahzad Goraya. He is no more with us. He passed away last night due to sudden cardiac arrest. He was the chairperson and the life member of the SOGP Salford chapter. So we are very, very depressed today, about this news. He was very young, enthusiastic, and very innovative person. And I feel sorry for his family. And I pray Inna Lillahi wa Inna Ilaihi Raji'un. I pray for him. Allah gave him in Jannatul Firdaus and gave the Sabr Jameel to his family. Inshallah, on behalf of the SOGP, we will arrange a condolence meeting next year. This is the tradition of our SOGP. Now I will welcome you all today to this webinar on Pre-Eclampsia. This is the first pre-symposium, SOGP symposium, which is ongoing on virtual symposium. And we welcome you all today in this webinar. And I welcome all the speakers who have given us time to this webinar. And as all of you know, that due to this COVID-19, SOGP has adopted or shifted to this new modes of innovative professional development through these virtual seminars and virtual meetings. And this is one of that example. So I hope every one of our SOGP members, viewer, nationally or internationally, or the healthcare provider will get benefit from that. I am thankful to all these speakers and my moderator, Professor Halima Yasmin. She is very kind to arrange all these things, and she is very committed to these.
Okay, so I think we are going to hold a very, very important session, which is hypertension in pregnancy. The topic seems to be very simple, but as you deal with the patient, it's extremely, extremely complicated. The timing of delivery, the mode of delivery, when should you deliver, how should you deliver, is, I think, one of the biggest challenges with hypertension in pregnancy. It may be a little too late for the baby, or it may be a little too early for the unit. But the important thing is this, that whenever you are considering a condition in which the mother and the baby's both lives are at stake, you obviously have to consider mother. So for optimal time of delivery, I think this is one thing where all the postgraduates get stuck. Sometimes they would say 34 weeks, sometimes they would say 35 weeks, and then they would say 37 weeks. There should be very clear-cut criteria which should guide us that yes, now is the time to deliver. You are just taking this pregnancy along so that the fetus becomes mature. But if, according to the Doppler, the fetus maturity is at stake, the fetus time is at stake, so you wouldn't like to have an IUD before delivery. So what is the optimal time? But obviously this would be different in UK than in Pakistan, and it would be different in different centers of Pakistan. And this is a huge problem which we face day in and day out, to make a decision that yes, now this patient needs to be delivered. When it is for the mother's sake, I think it's easy for us. We can do this at all places which are well equipped with obstetric units. But when it comes to the fetus, since we have very poor neonatal ICUs in majority of the hospitals, it becomes a huge problem that you need to deliver because the fetus is having reversed diastolic flow, etc. And you think that if there would be more benefit in delivering, but then you will have to deliver this baby by cesarean section. And at the end of the day, if the cesarean section is not, I mean, you've done a cesarean, so you've optimized her obstetric history as well. And at the same time, if you are unable to make the neonate survive because of poor neonatal ICUs, I think that's the dilemma which we face here in Pakistan. It may be very different in UK. You can do in utero transfers of mother as well to the places which are well equipped for this. But over here, the families usually refuse just to take the patient, and taking them from one place to the other also may be dangerous for them. So I think the whole dilemma or the whole process should focus at this, okay, which is the most appropriate time to deliver, where mother condition is concerned and where fetal condition is concerned, because that's the only way we can save the mother and hopefully the fetus as well, if we take an appropriate decision at an appropriate time. Because having eclampsia obviously is bad obstetrics. If a patient is under your care, at least you should not fit. You may not be able to stop a very high, severe preeclampsia, but you should be able to stop eclampsia from occurring. So the right decision at the right time. I think that's the most important thing. Rehana, what do you think about this?
Assalamu alaikum. Thanks for, I would like to thank SOGP for inviting us as a chairperson for this very, very important topic, as Professor Rizwana just mentioned. What I can say about this topic is perhaps that as we are getting older as obstetricians in Pakistan, we are seeing eclampsia and preeclampsia presenting now entirely with a different presentation, entirely with a different frequency, and with the extent of complications. As postgraduate students, when we were trained about 25 years ago, we would see patients with eclampsia, but not to the extent of complications which we are seeing them now. As Professor Rizwana mentioned about the timing of delivery, that is the main dilemma which as obstetricians we are facing. But the extent of complications, the extent of morbidity and mortality associated with preeclampsia and eclampsia perhaps has stayed unchanged. And particularly in the post-COVID era, we are now seeing more and more of these complications. Maybe the antenatal patients did not get the antenatal care which they seem to have got before COVID, and particularly in these 4 to 5 months. Yesterday, when I was looking through the statistics of our hospital, which is a tertiary care hospital, astonishingly, we found out that the frequency of preeclampsia and eclampsia post-COVID has changed dramatically. Now, we saw that about 10% of our pregnant population would present with hypertensive disorders of pregnancy. And out of these 10%, 3% would present with eclampsia. And out of the 3% of eclampsia, they all had major morbidity in terms of DIC, in terms of HELLP syndrome, cerebrovascular accidents, and being shifted to intensive care unit for further care. So the dilemma which we are...
Rehana, I'm sorry, I'll be cutting you. I think Halima's internet is not working at the moment, so I think we should start with our session.
Yes.
So I would first of all request Dr. Manu Vatish from University of Oxford to please begin his presentation. Really sorry for the digital problems which we always face, but I mean, just go ahead with your presentation, Dr. Manu. Thank you.
Don't worry about digital problems. We have them everywhere. Zoom problems are everywhere. Thank you very much for inviting me. I'm just going to start with my presentation. So let me share my screen.
Yes, we can. Yes, we can.
Yes, we all can see it.
Okay. So I'm going to talk to you today. Let me tell you a little bit about who I am. So I'm an academic obstetrician working in Oxford, which means that for 50% of the time I do clinical practice on calls, clinics and delivery suite. And for the other 50% of the time I do research. And I do roles as I'm involved in rolling out clinical research across the Thames Valley. And I'm also academic training program director for the Clinical Academic Graduate School and the college tutor for Oxford. Today, I'm going to talk about preeclampsia, and as people have very neatly said earlier, it is a complicated disease. And, you know, we get these two, hypertension and proteinuria, but actually the myriad of the ways that this disease can present is rather different and rather complex. And we can get mostly blood dyscrasias, or we can get visual disturbances. And as Professor Chowdhury said, you know, this fitting patient is for us rather a failure. You know, we shouldn't let that happen. The problem with preeclampsia is what we're using to diagnose it. And actually the diagnostic gold standard in most countries in the world remains hypertension and proteinuria. But the problem with hypertension and proteinuria is that they're poor. So if you look at the old NICE guidelines, hypertension and proteinuria are rather poor in predicting the clinical onset of disease and its progression, and so poor that we changed the way that we diagnose preeclampsia to incorporate these different aspects of the disease. So there's changes in bloods or ultrasound for the baby. And what we're trying to do here is encompass the complexity or the heterogeneity of the disease. But if we focus on what most people use, which is hypertension and proteinuria, we've known it's a pretty poor way of looking at preeclampsia for rather a long time. So Jim Roberts in 2001 decided to look at the positive predictive value of predicting an adverse outcome by either hypertension or proteinuria. And he used the American College Guidance or the ISSHP diagnostic criteria. And when you look at the positive predictive value for predicting an adverse outcome, it's actually only around 20%. And another way of looking at that is to use this sort of ROC curve. And of course, as you all know, if you have, the way the ROC curve works is that if you have a line that goes from this corner to this corner, it means there's really no benefit. There's no difference, it's just doing nothing. And if you have a line that comes up and goes up like this, then the test or whatever you're doing is of good value. And you can see that putting the systolic blood pressure or the diastolic blood pressure, either with or without proteinuria, really doesn't deviate the line from no benefit. What do we know about the pathogenesis of preeclampsia? So if you put pathogenesis of preeclampsia into PubMed, you'll probably get several thousand papers. And you can see that there are lots of different people's theories about what factors might drive the disease. But I think the key common element is that the placenta is at the heart of it. And we know that there's some lesion localized in the placenta in the first and early second trimester. And what that does is lead to the preeclampsia syndrome, which occurs in the late second and third trimester with all the aspects of the disease that we all know. There's been an awful lot of focus on things that might be released from the placenta that might cause the hypertension, proteinuria, and the other complications. And more recently, this attention is focused on some biomarkers that are released from the placenta, and these are called soluble FLT1 and PLGF. And we learnt about these first in 2004 from a seminal paper by Levine et al. In the New England Journal of Medicine. And what they did was they had a large body of patients who'd been recruited actually for another trial. They'd been recruited for a calcium for the prevention of preeclampsia study. And what they did was they analyzed the blood samples that they had of these patients for soluble FLT1. So soluble FLT1 is the short form of soluble FMS-like tyrosine kinase. And if we look at what happens in normal pregnancy, you can see the blue line. These are patients who had an entirely normal pregnancy. And you can see that the pattern for soluble FLT in normal pregnancy is that it stays relatively constant and then rises towards the end of pregnancy. But in the cohort of patients that had severe clinical preeclampsia, you could see that the soluble FLT1 was significantly elevated. But interestingly, in the women who had preeclampsia later, in the red line, you could see that it was higher than control, but not quite as high as those patients with established disease. But there was a clear significant difference between control. In the same patients, these investigators also looked at PLGF. And so PLGF is another placentally derived factor called placental growth factor. And here the pattern of PLGF release in pregnancy is rather different. And so in the same patients, you can see that the blue line, the controls, the normal pattern of PLGF release is that it rises to an apex in the middle of pregnancy and then falls as you start to get towards term. And in the same patients who had preeclampsia, those ones who had a high soluble FLT had an extremely low PLGF. And the patients who got preeclampsia later in the red line, had a pattern that was in between the control and the established disease. So people latched onto this and first of all started to ask the question, can we work out who or who has not got the disease at presentation? So if you look at this paper, which came out in 2012, these investigators looked at 457 women, of whom 48 had preeclampsia and 409 were normal. And when you look at the soluble FLT, you can see that the soluble FLT was elevated in these patients who had preeclampsia, and the PLGF was concomitantly lower in those same patients. And there needed to be a way of representing the contribution of soluble FLT and PLGF. And the idea was to then create a soluble FLT1 PLGF ratio. And the idea of using the ratio is that it allows you to accurately reflect the contribution of the soluble FLT rise and the PLGF fall. And when you analyze with the ratio, you can see that the patients who have the preeclampsia have a much higher ratio than the patients who are controls. But what about its accuracy? So if we look at the way the prediction of predicting an adverse outcome, and we have a ROC curve presented in a slightly different style, but essentially the line is going from this corner to this corner saying there's no benefit. And you can see the commonly used things that we would use to try and assess adverse outcome, like ALT or systolic blood pressure or uric acid in the green or creatinine, are all outperformed by the soluble FLT PLGF ratio for predicting an adverse outcome. So at this point, people started to ask the question, and of course, obstetricians are rather conservative people, and obstetricians said, well, you know, we think we can detect patients who have preeclampsia from not have preeclampsia. And so the question was asked, is it possible to predict outcome in pregnant women with suspected preeclampsia? So i.e., can you use these biomarkers to tell you what's going to happen to this patient? And so this study was called Prognosis, and this was a global study that involved many centers around the world. And subsequent to this study, there's been a Prognosis Asia study that has focused on Asia, which shows largely the same results. But in this first study, which I was involved in, we had 32 centres and 1,273 subjects with suspected preeclampsia enrolled. And there were two very simple questions. Well, first question was, is it possible to see a patient with suspected preeclampsia and rule out preeclampsia for the following 7 days? So can you do a test? Can you say this patient has not got preeclampsia and then be confident that nothing is going to happen to that patient for 7 days? And second question was, is it possible to see a patient with preeclampsia or suspected preeclampsia and rule in preeclampsia in the following 4 weeks? So I don't want to talk about all the analysis. I'm just going to go straight to the results. So using the soluble flip PLGF ratio cutoff of 38 or less, you can rule out preeclampsia within 1 week with a 99.3% negative predictive value. So the way that the test was designed, or the cutoff was designed, was that half the patients were produced into a development cohort that allowed us to define the cutoff of 38. And then once that cutoff had been defined, the other half of the patients were used to validate this. And you can see the negative predictive value is 99.3 with a very tight confidence interval. And then you can see the sensitivity and specificity are rather good. For ruling in preeclampsia, this was, can you do a test in somebody and tell whether the patient is going to develop preeclampsia in the following 4 weeks? It was less impressive than the negative predictive value. And you can see here that a ratio greater than 38, you could rule in preeclampsia with a positive predictive value of 36.7%. And you can see here that the positive predictive value in development cohorts and the validation cohort were rather similar. But I will, for those of you who are fetal medicine, maternal fetal medicine doctors, you will know that actually in current practice, the best test that we have, which is using Doppler and assessment of the risk factors, actually generally the best positive predictive value we have is around about 25%. So actually 36.7% is good, but not as effective as the 99.3% negative predictive value. So these findings were published in the New England Journal of Medicine in 2016. And rather than going through hundreds of papers and telling you about what this does or what that does, I thought the easiest thing to do was to summarize all the papers into one figure that would allow everybody to get the benefit of all the publications that have been produced. And so this figure will really summarize all the data that there is. And effectively, you can see on this axis, on the vertical axis, you can see the number of weeks from gestational age. So you can see 20 weeks and you can see 34 weeks gestation. And then you can see here on the lower axis, you can see the ratio of 38 and then a couple of other ratios of 85 and 110. So let's go through this figure. You can see that at any gestational age, if you have a ratio less than 38, you have a 99.3% that the patient has not got preeclampsia or will not develop preeclampsia for at least 1 week. If you look at patients who are below 34 weeks and they have a ratio above 85, it's highly likely that they've got preeclampsia. And if you see patients above 34 weeks and their ratio is above 110, it's highly likely that they've got preeclampsia. In this interval period, or the intermediate period, between patients with a ratio between 38 and 110 above 34 weeks, or 38 and 85 below 34 weeks, what this result is telling you is that these patients are higher risk and they need to be monitored more closely. So you can see that if you use these gestational age specific cutoffs, there's some advantage to using the ratio in aiding the diagnosis and prediction and short-term prediction of preeclampsia. But these tests were all done on cohorts that were retrospective. We knew what was going to happen to those patients. We knew the outcomes of those patients. And really what we needed to do was an interventional study. And so last year, we published the randomized interventional study of called INSPIRE. So this is a randomized interventional study on the prediction of preeclampsia or eclampsia in women with suspected disease. And the way that we did this study was that we had patients who came with suspected preeclampsia, and then all of these patients had a blood test. They had a blood test. If they agreed to take part in the study, they all had a ratio test taken in addition to their routine bloods. And in half these patients, the laboratory decided to reveal the result to the study team. And in half these patients, the laboratory decided not to reveal the results to the study team. So it's the same clinical team, same group of patients, and the only difference that we have is that we have the benefit of the ratio in this group, and that we don't have the benefit of the ratio in this group. So when we look at the trial demographics, we can see that actually there's largely no difference, other than in the reveal arm there seem to be some patients who were slightly heavier than in the non-reveal, but everything else, smoking, ethnicity, their blood pressure at presentation, the diastolic, was the same. And so what did this study show us was that it says that what you use when you have the benefit of the test is that all the patients that you developed preeclampsia were successfully admitted. And when you look at the patients, when we same study clinical team doesn't have the benefit of the ratio, actually 3 patients were sent home, all of whom developed preeclampsia within 7 days and became rather sick. And so you can see that the advantage of the test is that you're able to accurately identify every patient who's going to get preeclampsia. The other advantages were that you could see that the patients that you were admitting were actually the higher risk patients. So if you look at the 2 red boxes and you look at the non-reveal on the left and the reveal on the right, you can see that we were admitting babies that were smaller compared to standard practice. And actually the ones we're sending home ended up being heavier. So what that's doing is the test is allowing you to segregate patients better than your standard clinical practice. And similarly, we had significantly worse APGARs in those patients who were revealed, and we had more SCOBU admissions in those patients. So you can see that in standard clinical practice assessing the same patients, we're not identifying, with the benefit of the test, more high risk babies are being born and therefore being admitted. We're also identifying more small for gestational age babies. And the only way that we're doing that is with a test, a blood test. Similarly, if we look at the blood tests in these women, the women that we use the test on admitted rather than just using our clinical acumen and admitted had worse urates, had lower platelets, and overall we had a lower gestational age at delivery, which tells you that you're more likely to be admitting higher risk patients. So what we did was we wanted to look at the performance of the test. And so these are 2x2 tables at the top. But I think what we need to look at is that if you look at the lower table, and you can see that standard clinical management, which is on the left here, you can see that we have a sensitivity of 83%, a positive predictive value of 31%, and a negative predictive value of 97%. If you look on the right column, look at the ratio alone, and you can see the sensitivity of the ratio compared to standard clinical management is 95.8%. The positive predictive value is 41.1%, and the negative predictive value is 99.2%. But don't worry that your jobs are in danger, because actually when you combine standard clinical management and the ratio, you can see that we achieve a sensitivity of 100% and a negative predictive value of 100%. So combining a good clinical assessment with the ratio improves the precision of what you're doing. If you look at this the other way, you can see that the rule-out test And I think that it doesn't matter what these numbers say. I think the sentence at the bottom is the most important. So of the 256 patients with a ratio of less than 38, only one developed preeclampsia. And she was an inpatient because her blood pressure was high and she crossed the threshold for admission for blood pressure. And so you can see that this is an exceptionally powerful tool compared to standard clinical management. And when we break down the figures in a different way, we can see that actually, if you look at the preeclampsia in the 7 days in the whole population, so we look at our whole recruit cohort, we can see that if you had a ratio of less than 38, 70% of the patients that you see with suspected preeclampsia actually have a ratio less than 38. And of those, there's a 0.4% chance of getting preeclampsia. In that same group of patients, if you look at the patients with a ratio above 85, so that's every patient within the group of 380 patients have a ratio above 85, they have a almost 57% chance of developing preeclampsia within the following 7 days. And if you look at the patients with a ratio between 38 and 85, 1 in 5 of those will develop preeclampsia within the following 7 days. So I think infographics are usually, I don't like infographics, but I think this infographic summarizes the whole trial rather well. So you've got clinical practice plus the ratio with patients with suspected preeclampsia, and using the ratio, what you admit is more high-risk patients and you admit less low-risk patients. And what you send home is you send home more high-risk, low-risk patients and less high-risk patients. So this data, along with a range of other data, was submitted to NICE. And in 2016, our preliminary data from the trial, along with the prognosis study and several other pieces of data, allowed the National Institute of Clinical Health and Care Excellence to recommend the use of these types of biomarkers for the exclusion of preeclampsia. And last year, the NHS Accelerated Access Collaborative chose these tests in order to fast track them for dispersal and accelerated uptake throughout the NHS. And so currently the NHS is giving these tests free to any hospital that wants to use them. And there are plans to make the tests part of routine care. So in Oxford, we started using ratio testing routinely as soon as we had finished the trial. And the reason we did that was that the clinicians that I work with, when we finished the trial, said, where's that test gone? We need to use that test. It's a really good test. And so there was a drive from the consultants who had been exposed to that test to start using it. And it was driven by the clinical utility, the clinical accuracy, improved patient safety, and it worked out to be cost neutral. So I'm just sharing with you our network protocol for the use of soluble FLT PLGF ratio. So this is the network protocol throughout the whole of the Thames Valley. And you can see that we see patients with suspected preeclampsia.
Dr. Manu,
yeah.
may I interrupt you? Have you stopped sharing your screen?
I haven't. Let me.
We can't see anything screen share from your side. Okay. That's great. Thank you.
Can you see that now?
Yes, we can.
Okay. So, we, as I said, we adopted the test in Oxford based on these factors of utility, accuracy, safety, and cost neutrality. And here you can see the network protocol for the use of soluble FLT throughout the Thames Valley. And so this is outpatient suspicion of preeclampsia. We do the soluble FLT PLGF ratio. And actually, we initially started using the test to 35 weeks gestation, but we know the test is effective to 37 weeks gestation. And because of COVID, we've opened the testing out to 37 weeks because we know it's probably safer for the mother not to come into hospital at any gestation if we can send her home. And so you can see here that if the ratio is less than 38 between 24 and 37 weeks, and those figures from our trial, there's a 0.4% risk of preeclampsia within 7 days. And when we look at those tests, our study data, we can see actually there's less than a 3% risk of preeclampsia within 28 days. So we don't admit these patients. There's no admission unless there's a hypertensive issue that needs correcting. If you look on the right-hand side, if you have a ratio above 85, there's a 56% risk of preeclampsia, and they're at high risk, and they need a senior review. So this is where experience comes in, and some of the panel members on this webinar are all experienced doctors, and they're the people who need to review that patient and make a decision. You need to strongly consider, if that senior clinical review is not available, then the doctor who is unsure should consider admitting that patient until they can get a senior review. And then you have the intermediate ratios. And so here, there's a 20% risk. And we've divided this up pragmatically in Oxford, which is if they have proteinuria, then you should consider them high risk and monitor as if they're preeclampsia. And if they don't have proteinuria, then no admission, but twice weekly monitoring as an outpatient. So I'm hoping that I didn't need to convince you that preeclampsia was a placental disease, but I am hoping that I have convinced you that soluble FLT and PLGF are disease-related markers. And the ratio can rule out disease, and it depends on the paper you look at, between a 99.3% to 100% negative predictive value for the following 7 days. And it can rule in disease with a 40% positive predictive value overall. I'm hoping that I've persuaded you that using gestational age cutoffs can improve prediction. And it's a useful additional clinical tool. It's not a substitute for a clinical assessment. It's not a substitute for a history and examination, but it is a very useful way of segregating patients that you're worried about. And as I said, we're interested in, we're using it routinely at the John Radcliffe, and actually now, I think at the last count, there were 80 or 90 NHS trusts within the UK using this type of testing. I would very much like to collaborate, and if the people are interested in collaboration, I'm very interested in talking about the relationship between COVID and preeclampsia. But at this point, I'll stop this particular presentation, and thank you very much for your attention.
Thank you, Professor. I must appreciate a wonderful presentation and in a very done in a very good manner. My question is, what would it cost per patient?
It's different in different parts of the world, and I don't know what the cost would be in Pakistan. I can tell you that the variable cost, the cost of the cartridge is about £50, and then there's the cost of doing the test, and so that's the lab technician time on top. But of course, each region would negotiate I guess Roche does a different.
Is it a kit based or it is a machine based? Do we need a bigger machine for this?
It's a platform based. We have a very small benchtop machine, so the most of the Roche tests are machine based systems, but you have these really large things that are in tertiary centers. But our hospital is not a Roche hospital. We're actually an Abbott hospital, and our equipment comes from Abbott. But we had a benchtop analyzer, which is about the same size as a PC, and so you can analyze them on that.
Is there any specific company which is doing it?
So the soluble flip PLGF test is Roche Diagnostics.
Roche.
There are other companies that make tests that use other parts of the test. So there's a company called Quidel that just delivers the PLGF part of that test. And there are other companies coming through that do sell soluble flip PLGF, and I think Thermo and another. But the NHS, the NICE did not feel that there was enough data to support the cutoffs that they were using. So I think those companies are currently trying to generate data to say that they're as accurate, but they haven't got the data that didn't allow them to be recommended by NICE. So currently the two tests that are recommended are the Roche test and the Quidel test. We're not allowed to use them, they're not approved.
And Dr. Manu, how long does it take to
I would request
complete?
Madam Rizwana and Madam Rehana to kindly give their comments on the talk. Madam Rizwana and Madam Rehana Rahim, the chairpersons, to kindly comment on the talk.
Okay, I think it was really interesting, Dr. Manu. And I mean, we sitting in this part of the world, the biggest dilemma is when to admit the patient and when not to admit the patient. Because people over here have a very poor home monitoring system as well. And if we let them go, if they have say a marginally raised blood pressure and you're not too sure, and if we let them go home, they may not come back for their routine. I mean, if we tell them twice a week checkup, even at their home place, they may not do it, and they may come back with eclampsia. So I think a test like this would be an excellent test if it is made available and if it has such a good negative predictive value, and it can detect people who would require admission. I think this would be a big breakthrough, because whoever comes with a little high blood pressure, which has developed for the first time in pregnancy, we have a tendency to get them admitted. And that has a lot of burden on the patient as well as on the hospital, both. But you just don't know when to discharge them. Should you discharge them or not? It may risk their lives. So a test like this would be excellent to do. And my one question is, how long does it take for the test to be delivered back? That is the timing of the test. So, is it a strip-based test?
No, it's a lab-based test. So what we did was we get the test results back within the same time that we get the full blood count and the USNEs and the LFTs. It's the same turnaround time. It goes to the lab and you know, they divide the blood sample into the three machines. One goes to the full blood count machine, one goes to the LFT machine, and one goes to the soluble flip machine. And then they come back to us within a very quick turnaround. And I highly agree with you, Professor Chowdhury, that for us, it's the same. You know, pre-test, you're relying on instinct. And doctors' instincts are, we are naturally cautious people. You know, we don't want to make a mistake. We don't want to be the person who sent the wrong patient home. And so the test is exceptionally useful for reassurance.
Absolutely, Dr. Manu. I think this would be a big breakthrough if it comes up in a routine testing of preeclampsia.
Thank you, Madam Rizwana. Thank you very much. May I now request, if the comments from the other chairs are not awaited, then I'll request my next speaker for the session, Professor Arshad Chauhan. Professor Arshad Chauhan is the Medical Director at Crafts Infertility Center. He's been the Chair of Gynae and Ops Department at King Edward Medical University. Professor Arshad is writer of different books and book chapters, and he's the Chair of the Lahore chapter of SOGP, currently, and he is also member of faculty for CPSP. So may I request Professor Arshad Chauhan to kindly start his talk. He is going to talk about the institutional experience in preeclampsia in our national context. Thank you, sir.
Thank you, Professor Lima. Can you see my slides? First of all, I thoroughly enjoyed the talk on the diagnostic tests for preeclampsia. And thank you, SOGP. Thank you, Professor Halima, Razia Karejo, Professor, and Professor Rizwana Chaudhary. I have been asked to talk about the situation in institutions in Pakistan. It has been very well briefed by Professor Rizwana how we are differing from the United Kingdom. Things are not marginally different, things are greatly different. And this is the institution from where I come from. It's an old institution established in 1860 called King Edward Medical University. And that's the place of work I'm going to share my experience with you. It is nicely located next to the big mosque, Lady Willingdon Hospital. It was established in 1930, which means both of these institutions were there before the inception of Pakistan. I'm going to present to you a data of last 1 year, which is, I didn't take the data from this year because this year is COVID affected, and a COVID affected year would have a number less than the normal ones. And if you want to know what we see in the outpatient, it is 95,000 patients are seen in the outpatient. As Mr. Vatish was saying, that his hospital is not that crowded with people, but for your information, we are seeing around 300 obstetrical patients in one setting of OPD, and they are catered by approximately 10 to 15 doctors. And you can very well imagine the workload. Among them, in 1 year, we have seen patients who were diagnosed to be PIH in the outpatient was 2,253, 375 were IUGR, and 96 were received at IUD with blood pressure. The indoor work, which is gynecology and obstetrics together, is 33,000 patients are admitted. We have 16,000 deliveries. And for your surprise, we have a cesarean section rate of 40%. When we say we have a cesarean rate of 40%, that means that we have poor antenatal services. We have poor coordination between the areas outside. And we get patients who are actually in the severe form of the disease or who are already complicated. In last 1 year, we had 73 deaths in the hospital, and we have 680 neonatal deaths, which means the complicated cases are referred, premature babies are delivered in the hospital, and then due to overwork and understaffed and under services, we have this kind of ratio which we see. When we come to preeclampsia emergency admissions, 1,000 patients are admitted through emergency. As Professor Rizwana was saying, that we have no option other than admitting the patient in the hospital. Eclampsia 325, emergency cesarean section due to eclampsia were 220, and emergency sections for preeclampsia were 159, and 10 patients had HELP syndrome. What are our issues? What are we looking at? One, we do not have guidelines for the country. We do not have uniformity in the services, and we do not have a uniform criteria for diagnosing PIH. Some people are, that's why we miss a number of patients to be included into PIH, and we include many patients into PIH who may not be PIH. Secondly, we have failed to train at a uniform level across the country to our juniors that what is the best way to take blood pressure during pregnancy, how taking blood pressure differs during pregnancy if you compare it with a non-pregnant woman. Ideally, the woman should rest for half an hour, and then she should be 45-degree head up, and the cuff should be at the level of heart. And this is not possible in our outpatient to take blood pressure in that manner. Lying blood pressure is low, sitting is higher, and standing is even higher. And sometimes we see our nurses taking blood pressure standing position, sitting position. So we do not have a uniform way of taking blood pressure. Patients are, they travel long distance. They have to wait in the queue, and sometimes they are agitated and their blood pressure is not up because of the hypertensive disease. It is up because of the circumstances what they have gone through. And you know, in our country, when the baby is born, all babies are not examined by the pediatrician at birth because 70% of our babies are being born at home. And home deliveries are not accompanied by the thorough examination of the babies. And for a girl, it may be the first time that she is examined thoroughly when she comes for antenatal checkup. And we find out that she has underlying cardiovascular disorder or anything which can be, she may be hypertensive from beforehand. We have not developed a habit of doing blood pressure and checking radial and radiofemoral delays and renal artery bruits to exclude other causes of hypertension to make PIH an absolute diagnosis. Then we are lacking, you know, the patient becomes pregnant. First of all, she is taken care of by her family. Then she is taken care of by a lady living in that area who has been advising people around. Then you choose a doctor, then you change a doctor. Then we do not have a system where we will have a liaison between the family physician, the family physician and the hospital. And transportation system is not uniform across the country to take patient to the hospital in emergency. So patient goes for antenatal care on our own to different places, and they go to the hospital where they want to save money. That is number one. Number two, when they are not taken by the private practitioners, when they are complicated to the extent that hospital, if some, God forbid, something goes wrong with the patient, the hospital will be in a position to handle the complication and mortality, and it will not go to an individual. And that is the biggest reason why eclampsia, preeclampsia is still as prevalent as it was years ago in the developed world. Number two, the next thing is that, okay, we do not have a test to make a diagnosis of hypertension. We agree that the patients are agitated and their blood pressure is high. But the next step is that, do we have services where we can keep them for a short period of time, where we can recheck their blood pressure after 3 to 4 hours once their agitation is settled? And that is the concept of day care, that we keep them for a day and we decide in the evening how many of them can go home. They are actually not hypertensive. That was a momentarily their BP was up and now it has settled back. So we need to work in that direction as well, that we are short in the patient sorting actually at a larger level. This results in overburdening of the antenatal ward. The services of hospital are exhausted, and the patients are not subclassified into high risk, medium risk, and low risk. Hence, those who are in dire need of urgent attention, they are missed, and low risk patients take their time when we are seeing 300 patients per day in the OPD. All tertiary care hospitals have got diagnostic services which are up to the mark for as far as routine is concerned, or as far as investigations for PIH are concerned. We do not have any issue in relation to, but we do have issues with blood transfusion, though it is not related to PIH greatly. The next issue which I want to bring to your attention is that we do not have a cutoff level across the country, though it is written in all textbooks, when to start antihypertensives. Generally, it is said that hypertension and pregnancy should be treated differently from non-pregnant women. Hypertension comes for the betterment of the baby. When baby is not getting enough oxygen, the blood pressure goes up to increase the uteroplacental exchange. And we treat the hypertension when it becomes dangerous for the mother. Generally, it is said that 160, 110 blood pressure is the cutoff, 170, 110 is the cutoff when the antihypertensive should be started. In Pakistan, it is a uniform kind of practice that any woman who has a blood pressure of 130/80, 140/90, they are started on antihypertensives. The result is that hypertension comes to rescue the baby to increase oxygen supply. That is lowered by giving the medicines, and oxygen is compromised in the baby and baby goes into IUGR. Secondly, the drugs are taken, the compliance is according to the patient. Patients generally say, when I get blood pressure, I take medicine. When it is normal, I don't take it. And we all must understand that methyl dopa is most widely used drug. It takes 6 hours to start its action, and its action lasts for 6 hours. It's not an emergency medicine. Labetalol has much quicker onset of action, and that's the reason it is becoming popular, and it does not affect the uteroplacental blood flow that greatly. And we all know that hydralazine is a rescue medicine, but unfortunately, sometimes it goes missing from the market uh, uh, like suddenly. Anticonvulsant we are using, MEG sulfate has become very popular in preventing, but at the same time, you know, it has a very narrow therapeutic window. It has to be kept between a very limited, if it goes low, it becomes ineffective. If it goes high, it causes respiratory depression. Diazepam for years and years is being used in Pakistan. And I have an experience of working in UK that in the hospital I was working, they were reluctant to give diazepam up to 5 milligram. In Pakistan, we are giving shots of 10 milligrams and control. It is very effective in controlling the existing fit, while MEG sulfate is available now. Zafa has made it available at a cheaper price. It was not available previously. And the experience with MEG sulfate is very good. And where am I? So next, our next issue is, Professor is one of, gave a thought to it, that if we have hypertension, on one side we have a risk that baby may die in utero or mother may develop complication of hypertension. On the other side, we have an issue of prematurity if we deliver it. You must have seen my slide earlier that 680 babies died in the nursery just because of majority of them were premature. So we are not, in all hospitals in the tertiary care services are not equipped extensively to cater for that large number of babies, plus to the premature babies which are born. I mean, in the developed world, 24 weeks survival is there at 20 weeks at certain places of state-of-the-art places. But we are still struggling with the 28 weeks division. Very few below 28 would survive with us. You know, we had mortality, 73 women died. Out of them, 19 were because of eclampsia, preeclampsia. It is a very high number. But the reason for the death was late arrival, unexpected shortage of the life-saving drugs in the market, and then intensive care services. You know, Lady Willingdon has a special disadvantage, the hospital I'm talking about, because it is an isolated maternity hospital and we do not have the other departments in the same premises. They are at a distance of 3-4 kilometers. And that distance takes approximately 1 hour to travel because of the traffic jam all the time. And these deaths we are facing and we are fighting with them. But basically the test which has been suggested by Mr. Vatesh is that if we can make accurate diagnosis in time, we can put them on, we can advise them right medicine at right time, and we can save them from death. Preeclampsia and eclampsia remain a cause of morbidity and mortality in Pakistan for times to come. Thank you very much for your attention.
Thank you, Professor Arshad Chauhan. I'm really grateful. I understand there are very sorry figures and there are situations which we can't help at our end, but it's our first step which we are taking towards the academic development of our participants, our members. Thank you very much for your contribution and a wonderful talk. May I now request Madam Rehana and Madam Rizwana to kindly give their comments, so then we can go ahead for the next talk. Madam Rizwana, please.
I think Arshad spoke out of his absolute enthusiasm, and as he always is a very good speaker in this respect. And I think all of us who have worked in government hospitals know what the volume of patient is and what the load of problem is. And that is why I was saying it would be a big breakthrough for everybody if you can make a decision safely that who to admit and who not to admit. because so I think I would like Rehana to comment on this because I've been commenting on so many things. So Rehana, if you can just give your further opinion regarding this.
Thank you very much. So now let me introduce my third speaker for today, Madam Rahat Najam Qureshi, a very senior clinician from Pakistan, working at Aga Khan University Hospital for many years. Madam Rahat has a wonderful experience of working in community through her research project called CLEP, which was Community Level Intervention for Pre-Eclampsia. This was a funded project by Bill and Melinda Gates. After that, Professor Rahat did another trial of predictive model for postpartum hemorrhage and sepsis study, which came from Grant Challenges Canada. The grant was given to her. Currently, she is a co-investigator in the maternal component of the Umeed No project, which is also ongoing 5-year project. Madam Rahat would be a very appropriate person to talk on the topic which she has been given by us. Thank you very much, Madam Rahat, for joining us. She'll be talking and sharing her experience regarding preeclampsia management in community setting in our national context. Dr. Rahat, to go.
Thank you, Halima. Can you hear me?
Yes, Dr. Rahat, very clearly, and we can see your slides as well.
My slide? Okay, fine. So thank you very much for giving me this opportunity to share our experience of introducing the community level intervention for preeclampsia, which has now been concluded and also been published. And our investigating team was, you can see our investigating team, and this was the brainchild of Professor Peter von Dadelsen, who is now at King's College Hospital in UK. So basically this CLIP project was all about knowledge translation, because many times researchers can investigate and can bring out many interesting findings in their labs or in the clinical areas. But the challenge is how we can bring about a positive change in the community from these findings, and how we can bring about some betterment for the average person in the community. And so obviously, to bridge the gap between the researcher and between the community, you require very dedicated policymakers, decision makers, funders, and also the healthcare practitioners play a key role in this whole process. To further talk a little bit about the knowledge translation project model, I would, you can see, if you can see on the slide, there are 3 processes here. The first process is in the darker blue or black color, which may seem to you, and that is the need and gap assessment. So before starting the CLIP project, we went through a 6-month exercise of needs and gaps assessment by going through the literature and by identifying the peculiarities of our health system, the peculiarities of disease presentation in women, especially in the rural areas, and looking at our health practitioners and their knowledge and their practice. So subsequent to this this engaging process of literature review and brainstorming and meetings, we then came up with a strategic plan to start the CLIP pilot project. The CLIP pilot project was a 6-month project in which we had developed, we tested the tools that we had developed in the community to identify whether our tools could actually capture all the things that we wanted to capture. And we also trained the lady health workers to see their response. And we also involved significantly the directorate of the Lady Health Worker Program for Sindh. And we are very grateful to actually the government of Sindh and to the Sindh Lady Health Worker Program for extending their full cooperation to us in this entire CLIP project. So after a 6-month CLIP, so this CLIP pilot project was run for 6 months, and we have published 3 papers from the findings of this CLIP project regarding the level of lady health worker education, their skill, regarding community engagement, and regarding the whole process of healthcare in Sindh specifically for preeclampsia. So 6 months after the completion of our pilot project, we then entered into the implementation of the intervention, which was the CLIP package. So this is the way that knowledge was then translated, and you will see the interesting aspects of it. So this project took place in the province of Sindh, Pakistan, and in 2 districts, Hyderabad and Matiari. So the light pink, I don't know if you can see the light pink defined area. These were the clusters that were not included, and the purplish or the darkish color, dark pink clusters was the whole area where the clusters were selected after randomization. So we tried not to have overlap of any clusters between each other, between the intervention clusters and the control clusters. And if you see on the right upper hand part of the slide, you can see a red line and you can see a blue line. So the red line was actually the expected participant recruitment, and the blue line indicates the actual recruitment of the patients as we went along the project. And if you see on the bottom of the X line, you can see from point 0, the first 6 months was the start of the pilot project for 6 months. Then there was a 6-month period, and then there was the start of the actual implementation of the definitive. So the overall loss to follow up in the entire project, if you see in the right bottom hand thing, you can see 4% were lost to follow up, but we managed to have complete follow up of all the rest. So if you look at this slide shows the comparison of the basic demographic or baseline characteristics between the intervention group and the control group. And if you see, you find that the maternal age, this gestational age at enrollment, schooling, parity was very much similar in both the groups. And as you can see, the population density was slightly higher in the control group as compared to the intervention group. And the lady health worker density was also slightly higher in the control group. This was not by design. This was a random selection of the control and the control clusters and the intervention clusters, because the randomization was done at cluster level and not at individual patient level. So in addition to the project being carried out amongst the women, we also had a male component in which we engaged the men in each community, which was being included in the clusters. And this process was called community engagement. So what it actually included was that in every small village which was included in the cluster, we had contacts, and we had contacts through the local people in the community of a person who would coordinate and get together the local men in the community, which included husbands of women who were included in the trial, school teachers, religious workers, and community heads in the form of chaudhris and vaderas, and other important people in that community, be they from the government or the non-governmental or the actual local people. So groups of 15 to 20 men were included, and in these were then educated about the importance of antenatal care, about the importance of identifying eclampsia, which is an important reason for morbidity as well as mortality in our country. And so the participants that were engaged, if you see the second part of the slide, the second part of the second row, participants engaged, we had about 54,398 participants that were actually engaged through this community engagement process. And this was a very important and a very significant and a very satisfying part of the CLIP trial, because it allowed us to interact with the husbands and the men of the community. And the feedback from this particular engagement was that communities now have awareness regarding preeclampsia, which they'd never had before. And lady health workers also learned regarding preeclampsia, blood pressure measurement, and to advise pregnant women for danger signs of preeclampsia. And another from the field coordinator, before CLIP, no one knew that a woman can die due to preeclampsia. community valued one-to-one education sessions with women. So as far as these sessions were concerned, there were sessions with women as well as men also. The women's sessions were the sessions which were taking place every time the lady health worker visited the woman. She would talk to them, and she would then also talk about them about preeclampsia. But the male engagement sessions were held separately from the female engagement sessions. So this particular slide is showing you the coverage, the POM coverage, appears on the MOVE coverage with the tablet of 11,000 pregnancies. And so this tells you about the engagement in the 11,000 pregnancies, and in the yellow is the number of antepartum visits, and the yellow visits here are the antepartum visits, and the blue visits here, the blue shaded area here is the number of postpartum visits. So at least a very large number of women had at least 3 visits. This is the density of the population, had at least 3 antenatal visits and at least 2 postnatal visits. So one of the interventions that we had recommended from so the Peers on the Move was actually an application which was used in part of the project, not the complete project. And in the other part of the project, it was done through algorithms. And in part of the project, we used the POM, in fact, a very large part of the project used the POM appliance. And in the POM visit, actually, so let me first just go back for a minute and tell you about the package that was the intervention package. The intervention package consisted of the lady health workers visiting the pregnant women who had been registered that they were pregnant by the lady health workers. They visited them once monthly, and during this visit, they gave them the educational package, as well as they checked their blood pressures. And when they checked the blood pressures, if the blood pressure was beyond 140/90, then the woman would then be advised to take Aldomet and two tablets of Aldomet. And if it was higher than 140/90, then she was advised to have magnesium sulfate and advised to go urgently to the hospital. So we, as part of the package, interventional package, we had also put in some money to help the patient transport her to the hospital, because in many of these places there was no ambulance services available, and people depended on their own transport or the transport of the community members to take them to the hospital. And if these were not available, then they depended upon the local rickshaw, kind of a situation. And there was a small stand, a taxi stand near each village, not very much near, but sort of, a reasonable distance from a village, where they could hire these public transport services, which would then take them to a hospital. So we had put in a little bit of money that they would be able to, which would help them, to assist them to travel to the hospital. So this was an important part of the whole package, because the lady health workers actually are not allowed, are not trained, not certified to give injections to patients. But because we have a precedence that the lady health workers give vaccines, which are both oral vaccines as well as injectable vaccines to patients, therefore we took permission from the lady health worker program to allow us to train the lady health workers to give the vaccinations, to give the magnesium sulfate intramuscularly. And the dose that was given was 10 gram dose into the buttock. And this was, they were trained to make sure that they followed all the infection control practices. So about 0.29% of the visits had a recommendation for magnesium sulfate according to the Peers on the Move application. And out of that, 57.8% had actually accepted. So initially in the program, the acceptance rate was much lower, but as we responded to the objections or to the comments of the community, and we found that the acceptance rate had increased as much as 80% towards the end, but on an average, because when we see from the beginning to the end, it comes up to about 60%. So Methyl Dopa was also given, the recommendation for Methyl Dopa, and we found a very high acceptance rate for methyl dopa when they were recommended to the patients. And as far as the non-urgent referral or less than 24-hour referral, in other words, the patient was advised that you should reach the hospital within 24 hours. We found that a majority of patients had acceptance, 77% had acceptance. And for urgent referral, again, a very similar number had acceptance. So urgent referral meant that they should go as soon as less than, so wherever magnesium sulfate was given, they were asked to go to the hospital immediately. So as far as the outcomes are concerned, I'm not going to go into much detail about the outcomes here because both our papers are out and those people who are interested can read the papers. But overall, we did not really find a lot of difference in the, so this is the intervention column and this is the control column. And so we did not find a very significant rate of difference between the maternal death rate or between the maternal morbidity rate. But we did find a very marked difference between the stillbirth rate, the early neonatal. So according to the sample and according to the p-values, we found a significant rate, the difference rate between the neonatal morbidity and morbidity rate, which included mortality and morbidity. So moving on. Like I said, I'm not going to go into too much detail here, but I would like to. So these are the names of all the clusters which were included in, for anybody who's interested, they can contact us and we can give them more details about this. But these were the interventional clusters: Bhanot and Haji Sawan Khan Gopang, Khatri, Karam Khan, Nizamani, Masu Burgari, Mulan, etc., Lal Station, etc. So as far as the adjusting for baseline and cluster first 6-month trial, this was after 6 months, but I don't have a slide for the full trial. So what were the reflections after the CLIP trial? So considering our overall objective for knowledge translation, we wanted to review and see how much of knowledge translation we were able to do through the CLIP trial. So some of the reflections which reflected on the main results of the trial was also that we really, in Pakistan, we have very limited data on baseline morbidities at the start or even at any point in time, because as you all know that in 2005, 2006, the first time Pakistan demographic health survey, the mortality data for women and morbidity data was included. And then recently we have had another study, another report on morbidity and mortality. So this is not done on a continuous basis. And our lady health workers, which are the basic primary health workers working at community levels, do not really register. They only register pregnancies, but then they do not register pregnancy outcomes in terms of morbidity. Some mortality is registered, but not morbidity. And as we all know, morbidity is much, much higher as compared to mortality. So most of the data that we have on morbidities and mortalities in Pakistan comes from tertiary level hospitals and academic teaching centers, where obviously we are seeing the tip of the pinnacle and not the entire iceberg. The second reflection is that in the lady health worker coverage in the CLIP areas, we found that there was a wide variation as the lady health worker program has gone through its own difficulties and its own challenges. We find that even though they are supposed to cover 100% of the population, but this can vary between 40 to 60%. And in CLIP, because in this trial of community level intervention for preeclampsia, we did not address facility-based care, even though we delivered some programs for education at the facilities in which the hospital doctors, the consultants were involved, but we did not follow it up to find out if that had improved or not improved. So we all know that quality of care in facilities is an important predictor of outcomes. Now, quarterly surveillance in CLIP Pakistan trial may have been an important intervention by itself. So apart from the intervention, just the fact that somebody is going, talking to the patients, the women, talking to the men, that by itself may have had a temporary or that may have been a very important intervention by itself. So the successes of our CLIP intervention include that the fact that the women in the community accepted the CLIP intervention, includes the ability of the daily health workers to triage, to treat without any adverse events. We did not find even one adverse event associated with methyl dopa or with magnesium sulfate infections.
May I please request all the participants to mute their mics? Kindly, all participants to mute their mics. Dr. Hart, you are requested to continue, please.
Can you hear me now?
Yes, Dr. Hart, thank you. Thank you.
हाणे मां म्यूट कयोमांसि वरी अनम्यूट लॻो पियो हेॾिस हाणे म्यूट कयोमांसि वरी अनम्यूट हाणे वरी म्यूट आहे हाणे त म्यूट आहे
Okay. So we found that a low resource model for engagement of male stakeholders in women's health issues can be designed, and it can be included because actually we have a large cohort of workers at community level who are the people who are the motivators and who are used in the family planning program. So, you know, we do have silos in which we have community level workers, but they're not working with each other, and therefore we are when we try to look at lady health workers alone, we are unable to deliver all the important applications in terms of engagement with the community, etc. And men talking to men would have a better result as compared to women talking, and especially young women talking to men. So the other success was that there was electronic data collection. There was all a paperless collection of data, and it was so all the physicians were blinded to the outcomes. So it was completely randomized, completely controlled, and blinded, so that we did not know of the outcomes until the program was completed. And our study is unique because it has provided population level estimates of maternal and neonatal morbidities. And so some publications are in process for the secondary data analysis of our CLIP trial, in which we will get to know more about maternal and neonatal morbidities in the community. And so feasibility study that we did in the beginning, the feasibility study, then the CLIP pilot project, it provided very important information on community-based perceptions of preeclampsia. So in the end, I would just like to say that this is the paper that has been published. This is the IPD, the individual participant level meta-analysis for Mozambique, Pakistan, and India. So this was a international study, and these three countries ended up with retaining their place. Pakistan had the largest sample size contribution of 20,000, whereas India had 10,000 and Mozambique had 10,000, and Pakistan actually led the way in the development of the protocol, in development of the tools that were used for the whole project. And so there is another study in pregnancy hypertension. Both of these publications have taken place this year. And this is the community level intervention. This was published in pregnancy hypertension. The IPD has been published in Lancet. And so if anybody's interested, they can go and they can log in to Google Scholar, and they can find out information about the results, the actual results and the final results of the study. So thank you very much, Harima. Over to you.
Thank you. Thank you very much, Dr. Ahat. It was really, I have the pleasure to, and I was very happy to be a part of the team in community by a collaborating partner of SOGP is having you today to present this wonderful community work, and I'm really grateful for presentation. May I include or give their remarks, and then Professor Razia would like to conclude. Madam Rizwana, to kindly give the
Ji, Rehana is Rehana not there? Halima?
Yeah, I am here, Dr.
Ji, so
Rizwana.
Rehana, please, will you give the remarks this time?
Yes. In fact, I had few remarks about the previous speakers as well. I don't know, is Dr. Vatish still there or not? Because I just had a query. If we start screening for our population in this setup, does he think that we'll probably get different results or different ratios in terms of Asian population versus Caucasians? This was just a query in my mind, and I would like to request SOGP and Roche to sponsor at least a pilot study in Pakistan, so that we can find out the disease pattern and ratio pattern for our population. The second comment regarding Professor Chauhan's presentation, an excellent presentation in the way this is how we face, all of us face the same situation working in tertiary care hospitals. But I was just wondering if again SOGP would make a better platform to make universal guidelines for Pakistan in terms of treatment of preeclampsia and eclampsia. And probably many issues can be sorted out in terms of blood pressure recordings, in terms of patients getting stressed if we have isolated or dedicated triage areas where blood pressures can be checked. And I would perfectly congratulate Professor Rahat Qureshi, such an excellent and commendable work going out to community, because we know if the community health workers and the population at large gets knowledgeable about the disease and progression, we can bring down our maternal morbidity and mortality. Thank you very much.
Thank you, Madam Rehana. Over to Madam Rizwana now.
Okay, thank you, Halima. I think it was an excellent session, and we've just shown three things. One was the advanced research, which can help us. The second was the actual situation, what we face in Pakistan, and third was a community-based study on preeclampsia. And all three are in the same direction, that we want to help the women of the world, and obviously we as SOGP women of Pakistan at large. And I think Rahat, it was a beautiful study, and Aga Khan has this great advantage of doing community-based studies, which is the need of the day, at least in our country, because in the communities, majority of the problems arise there, and then they are, once they come to the major hospitals, they are so much gone far ahead in their disease that really you cannot help them out. So if this is addressed there and then, that would be the best thing. And at least this has given a data of at least 20,000 people in Pakistan in the community. So I think, and I would really like to commend SOGP for conducting these beautiful talks, which is of use for everybody working in OBGYN. Thank you so much,
Thank you.
Halima.
Thank you,
Dr.
Madam.
Razia.
I'm really grateful to Dr. Manu Batish, Madam Rahat Qureshi, and Professor Arshad Chauhan, and Madam Rizwana and Madam Rehana for being with us. My special thanks go to Roche Pakistan office for supporting us to conduct this activity. May I now request Professor Razia Kurejo to kindly conclude the session and say a few remarks from her side. Madam Razia.
Thank you. Bismillahirrahmanirrahim. Thank you so much, Dr. Halima. First of all, I would like to congratulate all the speakers, three speakers, Professor Manu Batish, Professor Rizwana. Professor Rizwana is not a speaker, but the Professor Rahat Qureshi and Professor Arshad Khan for their very nice, very informative presentation on pre-eclampsia. SOGP has chosen this topic, pre-eclampsia and eclampsia, because this is the second most commonest cause of the maternal mortality in Pakistan. I have done the 30 years study in JPMC regarding the maternal mortality in Pakistan from 1980 to 2010, and I have found that in the first decade from 1980 to 1990, eclampsia was the the cause of the maternal mortality, about 20% of the maternal mortality was due to the eclampsia. Postpartum hemorrhage was the leading cause. Second commonest cause was the eclampsia and hypertension. And in those days, we were using the diazepam. But when we did the study from the 2001 to 2010, and it was found that there was a dramatically reduction in the maternal mortality from 21% to 10.9%. So there was 10% reduction in maternal mortality because in those days we were using the magnesium sulfate. So because of the magnesium sulfate, it was the very useful drug to reduce the maternal morbidity and mortality. So I think this topic was chosen from the SOGP. I think from all the speakers did very good job, their experience. I think every one of SOGP members got some benefit from their experience talks. So Dr. Rahat Qureshi did a lot of work on this pre-eclampsia. So I think Dr. Rehan's comments on this, that we will use the guidelines regarding the SOGP will do the guidelines. So I will request Professor Rahat, Rizwana, Rehan, and all of you, Professor Arshad Gandhi, please, all of you who do I will request all of you, please make guidelines for the SOGP guidelines for how to prevent and how to treatment of the pre-eclampsia and eclampsia. So I would like to congratulate Professor Rizwana Chaudhary and Rehana Rahim for conducting for chairperson and as a co-chair, and I will thankful to Professor Halima for moderating this session, and I am thankful to all the Roche Pharmaceutical Company for helping us in organizing this webinar. Initially, we have a problem of this internet, so maybe I was not welcome you in this webinar. So SOGP is doing on this virtual webinars because of this COVID situation. I think, again, I will thank you, all of you, for this participating in this virtual webinar. Thank you so much.
Thank you, madam. So, Dr. Vatish, I'm especially grateful to you for your presence as a special speaker from Oxford University, Professor Arshad Chauhan, Dean, CPSP faculty for gynecology, and ex-chairperson of King Edward Medical University, Madam Rahat Qureshi, a big name for us, a very respectable name whenever the work on pre-eclampsia and community comes in our national context. She has contributed immensely to the cause. And Madam Razia Khorejo for being here with us today. And last but not the least, my two chairs of the session, Madam Rizwana and Madam Rehana Rahim, for always being here for us whenever required and whenever we call you. And thank you for giving your remarks after every talk so beautifully and so clearly that it would have benefited all the participants who attended. I would request Professor Manu Vatish to be a part of our guideline committee as a support from UK, because he has immense work in research in this area. The role of biomarkers was really discussed very well, and let's look forward that we can also have these biomarkers available at a very affordable cost for our patients so that we can use them for early detection and better prevention of this disease. I really congratulate and I am grateful to all the members who joined us on Zoom as well as on Facebook. SOGP has a long way to go, but only with your support and only with your contribution and input. All my worthy members who are attending this webinar, either on Zoom or on Facebook, I'm really grateful to be a part of this team. This is a duty which is entrusted by all of you on me. I will try to fulfill it to achieve the cause and vision and mission of SOGP. Thank you very much, everyone. Assalamu alaikum, and have a good weekend. Thank you.